Dr. Dina Saleh. She's an assistant professor of pediatric neurology from Ain Shams University, Cairo, Egypt. She's a pediatric neurology consultant at the American Center of Psychiatry and Neurology in Abu Dhabi, UAE. She's going to talk to us today about lysosomal storage disorders from a neurology perspective, and this lecture is sponsored by Sanofi. Dr. Dina Saleh.
Assalamu alaikum, Dr. Ahmed. How are you? Well, I'm very happy today actually to see my neighbors back in Mafraq, Dr. Shatila, Dr. Shubit. Very, very happy at least to see you virtually. Thank you so much for your generous introduction.
And thank you for coming, and likewise, it's nice to see you. It's been a long time.
Yes, true.
So without further ado, I'd like to give you the virtual floor.
Thank you so much. Thank you, Dr.
Bye-bye.
Bye-bye. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. And as Dr. Ahmed mentioned, this is a symposium sponsored by Genzyme Sanofi, and today I'll talk about lysosomal storage disease from neurology perspective. So the objectives of my talk today is to provide a brief and overview on lysosomal storage disorder. As of you all know, some lysosomal storage disorders are treatable, so early diagnosis is really critical in order to provide a timely referral to a geneticist or metabolic specialist. During my talk today, I will highlight the key neurological manifestations of two treatable disorders. So basically, this is a family of more than 50 disorders recognized, and generally, as of all you know, the lysosomes is an intracellular vesicles where there is enzymes, hydrolytic enzymes that is responsible for expulsion of exogenous materials, bacteria, as well as cellular waste products. In case of deficiency of these lysosomal enzymes, there will be subsequent, of course, accumulation of substrates depending on where is this substrates and depending on which tissue or organ is affected, with for sure progressive accumulation of substrates and irreversible tissue damage. Looking at the incidence of lysosomal storage disorder, individually they are quite rare, but when we look at collectively they are quite rare. So the individual incidence would vary from 1 in 40,000 up to 1 in 1 million live births. But when we look on the collective incidence, it could be ranging more common into 1 in 7,000 up to 1 in 10,000 live births, meaning that healthcare professionals during their clinical practice might encounter one of these cases during their practice. Mostly it is pan-ethnic, however, some of those lysosomal storage disorder can be seen more prevalent among certain ethnic groups, such as Gaucher and Nemantic are seen more among Ashkenazi Jewish descent. And infantile onset Pompe disease might be seen more prevalent among African Americans. Here the slide depicts the relative prevalence of these individual lysosomal storage disorder among this group. So we can see that the most prevalent type is Gaucher type 1, which accounts for almost 13% of the cases, and of course followed by metachromatic leukodystrophy, which accounts for around 8% of the cases, to be followed by Sanfilippo type A, accounts for 7% of the cases. And as of you all know, lysosomal storage disorder is characterized by a multi-system and multi-organ involvement. Among this is the CNS, which is the focus of our talk today, accounts for roughly around 50% of the presentation. So 50% of lysosomal storage disorder might present with significant and severe neurological and CNS manifestations. Among the most common is metachromatic leukodystrophy, TB, followed by Hunter and Sanfilippo type A. Unfortunately, enzyme replacement therapy, which is available, cannot cross the blood-brain barrier, and hence it will not affect these CNS manifestations. Looking into the inheritance, almost all the LSDs are autosomal recessive inheritant, except 3 disorders that will be presented in the next slide, meaning that the defective gene must be presented in 2 copies in order to manifest as a disease. So a diseased patient would inherit 1 copy of the defective gene from each carrier parent. Having autosomal recessive carrier status render the chance of around 25% of passing the affected gene or the defective gene to 25% of the family members, and 25% of them will be neither affected nor carrier, and around 50% will be having carrier status same to their parents. On the other hand, 3 disorders were found to be X-linked inheritance, including Fabry disease, MPS type 2, and Danon, where the defective gene is carried on the X chromosome. In this case, we have 2 case scenarios. The first case scenario is the father having the defective gene carried on the X chromosome, and in this case, there is no male-to-male transmission, meaning that all the defective gene will pass into their daughters, so daughters will be 50%, the daughters will be carriers, and there is no male-to-male transmission. The second case scenario, if the female mother is the affected carrier, so there is a chance at least 50% of passing the defective gene into their generation. Sons all will be affected, of course, if they carry the gene, and daughters will be carriers. So here comes the importance of early diagnosis of LSDs being a very progressive, debilitating, and often life-threatening disorders. And having said that, treatment does exist, therefore early diagnosis is really important in order to provide early intervention and, of course, stop the disease progression and improve the quality of life. And for sure, there are many studies that have been done about the diagnostic odyssey and looking at how the number of physicians that have seen cases with LSD before reaching a definite diagnosis, and it ranges from as 6 physicians up to as much as 13 physicians seeing the patients with LSDs before reaching a definitive diagnosis. Having said that, just to introduce you that the diagnosis is very simple and easy when we have actually readily available this, as you can see here in this, the dry filter paper. It's a very easy and simple test available in our office whenever we suspect any patient with lysosomal storage disorder. These filter cards are provided by Genzyme Sanofi, where we can take few spots of blood, and we just simply can check for the enzyme assay and provide further confirmatory gene mutation analysis if needed. This slide actually presents the number of treatable lysosomal storage disorders, but for sure, for the sake of the time, we'll not be able to go through them all, and we will highlight 2 main lysosomal storage disorders. The first presented through a case. This is not my own case, but this is case published in literature for 2 siblings. Both of them have the affected, and one of them presented at the age of 12 years old, a boy with a chronic pain while walking and the severe burning sensation of both arms and soles of his hands and feet. He has hypohidrosis and heating sensation for the past 4 years. Additionally, he has been complaining of recurrent tummy aches, which was investigated with unrevealing etiology. He was diagnosed with chest planus and has been receiving physiotherapy over the past 2 years without appreciated improvement. Generally, he has been well built, and he was found to have a peculiar skin rash over the penis and the scrotum that I will show later. And of course, his neuro exam was normal. Based on these clinical symptoms, workup was done that showed EMG nerve conduction were normal. Renal functions have been investigated for suspicion of certain disease that we will discuss now, and it was unrevealing. Eye and hearing tests were both normal. So when we have this, constellation of symptoms, having a patient with a chronic pain, GIT symptoms, what would we think next? So the easiest way is to think that we need to do a dry blood spot, daily ask filter paper to check for enzyme activity. And here we found that the patient had alpha-galactosidase enzyme deficiency. Now, Fabry disease is providing an overview about Fabry disease. Fabry disease is a low prevalence disease. It has been described by 2 independent physicians, as you can see, more than 100 years in this photo, and the estimated incidence is 1 in 40,000 among men and 1 in 20,000 among women. As I mentioned earlier, it's an X-linked inherited disease. It is basically due to deficiency of alpha-galactosidase enzyme with the resultant accumulation of single lipids, GL3 typically, globotriaceramide, oxyceramide, and this will result in progressive inflammatory process with a progressive tissue damage. Actually, the Fabry disease have a wide clinical spectrum of phenotype, and this is related, varying from mild forms up to severe, well-established forms. This is related to finding more than 640 mutation in the GLA gene has been reported. It has been related according to the age of onset, a rate of progression, and organ involvement, and also it differs being presented in males rather than in females. Usually in males, the disease is severe, and females, due to the inactivation of X chromosome, the enzyme might be normal, and further genetic analysis might be required in order to confirm such diagnosis. As I mentioned earlier, the pathophysiology is related to the continuous accumulation of the GL3 in different tissues and organs, including kidney, central nervous system, and the heart.
Sorry, I think your is your microphone caught on your headdress or something, because there is some crackling.
Sorry. Yeah. Okay. So shall I start from which slide?
No, it's okay. I just said
okay. Thank you so much.
Just hold it there, I think it was catching there.
Yeah. Okay. Thank you so much. Yes, I'll proceed.
Oh, yes.
I'll proceed. Thank you. So looking at the disease progression, we found that during infancy and childhood, the symptoms would not be much evident, but over time, during the adolescence and adult period, there will be progressive organ in tissue involvement with the progressive organ failure and, of course, premature death. Looking and zooming into neurologic manifestation, which is the core of our topic today, that, as I mentioned earlier, the main presentation of the first most common symptom would be chronic attacks of severe pain, burning pain in hands and soles, might be GIT problems, unspecific symptoms of diarrhea, tummy aches, hypohidrosis, headaches, and of course, for sure, depression due to the presence of severe chronic debilitating pain that is not responding to any types of therapy, and of course, affecting the quality of life. It has been reported also to have transient ischemic attacks, unspecific white matter lesions, and eventually stroke and premature death. So in this slide, I show a lay stress on the neurologic manifestations, and saying, having said that, stroke is very important. And when they looked at the overall incidence of stroke, they found that the mean age among males would be around the age of 40s, and in females around the age of 45, and this is way much higher as compared to the general population. Other clinical manifestations would be this typical rash with angiokeratomas, which is the red, purple, and non-blanching lesion typically seen in the umbilicus downwards to the thighs. Other clinical manifestations would be corneal opacities that can only be seen by slit lamp examination, a creamy-like opacity, as you can see there, that is not affecting the field of vision, known as cornea verticillata. The second case that I would highlight, one of the treatable forms of lysosomal storage disorders, typically a 3-month-old infant presenting with recurrent infection and acute pneumonia. His mother will say that he was born uneventfully, weight was fine, but over time he is not putting on weight, and he has been poor feeder, and they have noticed to have some paucity of motor movements. Generally, the child would look like frail appearing infants with tachypnea and tachycardia, with moderate maculoparesis, and on palpation of the abdomen, he was found to have liver 3 centimeters below the right costal margin. On providing ongoing neurological examination, there was found to have profound generalized hypotonia and with a head lag and a weak neck support. He was found to be profoundly weak both distally and proximally, and he was hyporeflexic. On doing further workup, chest X-ray was done, and that showed huge cardiomegaly, and routine labs were uneventful except for mild increased CK. Of course, having a child with these symptoms, severe progressive significant muscle weakness, cardiomyopathy, as well as respiratory symptoms, we have to suspect Pompe disease. And that can be easily again confirmed by doing the dry blood spot enzyme assay to show deficiency of acid alpha glucosidase enzyme deficiency. So now giving an overview about Pompe disease, and it has been first described in 1932 by Professor Pompe after the sudden death of an infant with idiopathic hypertrophic cardiomyopathy due to deficiency, as I mentioned, of acid maltase deficiency. It has many names: glycogen storage disease, because it's well known due to defective enzymes with a progressive accumulation of glycogen in the lysosomes. Eventually, it will get swollen, as you can see in this diagram, and eventually the glycogen will, the cell will, lysosomes will burst, resulting into glycogen going up in the cytoplasm with progressive tissue destruction and skeletal muscle, cardiac muscle, and smooth muscle involvement. And as I mentioned earlier, the inheritance is through autosomal recessive pattern, and the overall incidence is 140,000 worldwide. However, there are two forms that have been described. I will mention in the next slide. GAA gene have been located on chromosome 17q25, and more than 300 mutations have been identified to date. Looking into further classification of Pompe disease, that have been classified based according to the age of onset. So if the age of onset is below the first year of life, then we are dealing with infantile onset Pompe disease, and if it's above the first year or the first year of life, then we are dealing with late onset Pompe disease. It has been also further classified into infantile onset, either classical or non-classical form, depending upon the range of enzyme activity and depending on the age of presentation. The earlier the age of presentation, the more the classical form, and the more the earlier the age of death. The second form, which is the late onset Pompe disease, having been described after the first year of life, and either presenting during childhood and teenagers, and usually there is a residual enzyme activity up to 2 to 6%. Or the adult form, which presents usually after the second decade of life, and usually the death is after second decade of life, since they have residual activity of the enzyme up to 30%. I'll start with the first, with the infantile onset Pompe disease, and it's less prevalent than the late onset, presenting around 1 in 138,000 live births. And when we look at the first symptoms, they were noted at a median age of 1.6 months. And having non-specific symptoms, it really presents a challenge for diagnosis infantile onset Pompe due to similarity and sharing symptom signs with other neuromuscular disorders. So when they looked at the first symptoms through a Dutch study that described originally 20.
Dina?
Yes.
I'm sorry. 5 minutes remaining, please.
Okay. They found that when they compared this Dutch study, that they found that around 55% of Dutch patients, as compared to the 55% presented with feeding problems as compared to general literature, 40% motor problems, and 40% respiratory problems, and 15% with cardiac problems. Looking into the clinical spectrum in cases with suspected Pompe, as I mentioned earlier, they have feeding problems, poor head and neck, poor weight gain, and failure to thrive, paucity of movement. They have difficulty to acquire their gross motor milestones, rolling over, sitting, even never achieve it, and they have macroglossia and cardiac murmur and hepatomegaly. And when we look into the neurological examination, which is the core of our topic today, you will find the patient having gross motor delay, muscle weakness, and they have profound hypotonia. However, they appear to having social and adaptive responses are really intact. They have also diminished or even absent deep tender reflexes. And we look into hypotonia by inspection. This is the normal looking child where you have semi-flexed arm and lower extremities. And in the lower down, you find the typical frog-like position with the significant profound hypotonia. When you attempt to pull the infant, there is in the upper photo, this is a completely normal child with proper head control. In the lower picture, you can see that there is significant head and neck lag. And on vertical suspension, the left side, this is completely normal child. On the right side, the child is slipping from the examiner hands. And on ventral suspension, you can see the profound hypotonia where inverted C shape of an infant. Coming to the late onset Pompe disease, as I mentioned earlier, it presents usually after the first year of life. The incidence is much more common than infantile onset, 1 in 57,000 live births. They might present with non-specific manifestation of the GIT symptoms, the swallowing difficulties, dysarthria, or even some evidence, of course, of limb-girdle muscular weakness, waddling gait, difficulty climbing stairs, and sleep and disordered breathing. And typically they find myopathic facies with mild bilateral poses. They might have protrusion of the tongue, scapular winging, positive Gower sign, and diminished reflexes, and of course spine deformities. And sometimes they do present to orthopedic surgeons for treatment, and unfortunately they will not be diagnosed. So this is a briefing up of the previous 2 slides, and I'll skip them for the sake of time. So diagnostic testing easily, readily available in our office, very easy. CK is done, mild elevation of CK or transaminase, then we can do the dry blood spot offered by Genzyme, and then we can send for further genetic analysis for confirmation. This is the very important slide about the diagnostic algorithm when we look having history of proximal muscle weakness, suggestive of limb girdle distribution, restrictive respiratory insufficiency, or asymptomatic hypercykemia. We have to do the dry blood spot for enzyme assay, do the genetic analysis, and then easy as that in order to provide early diagnosis and to offer early intervention and treatment in order to stabilize the pulmonary function and disease progression and improve the quality of life. My take-home message to all healthcare professionals that clinical suspicions by finding a unique sign or symptom or by cluster of common signs and symptoms is the key to improve diagnosis and avoid diagnostic odyssey of rare disorders. Diagnostic tests are simple and available. If ever you are not comfortable, just refer to a metabolic or genetic or a neurologist whenever needed. Enzyme replacement therapy are available, and for sure it might provide better outcome. Just to share with you, this is a very important website that has been launched by Genzyme Sanofi, RD Nexus, in order to help you. You can easily register here, and you can easily also request this enzyme test, and you can also ask an expert or even entertain reviewing very educational and nice videos about rare disorders. And I would like to share with you also the this NGC project, which is by Genzyme Sanofi, also entertaining different, at least 9 genes of myopathies, limb girdle myopathies, in order to motivate genetic testing for limb girdle as well as Pompe disease, to create awareness about Pompe disease. It's a very simple and easy test, also again through the dry blood spot test, and it's available in the kits. I have it in my office. It's very easy and helpful. Thank you so much, and hope thank you so much for your attention.
Thank you very much.
I hope I make it on time.
You were perfectly on, actually, with 1 minute to spare, actually.
Okay.
Thank you for the very interesting lecture. You know, lysosomal storage diseases, it's a large spectrum of illnesses, and yes, like you said, you know, they tend to cluster, but you have to have a high degree of suspicion, right?
True.
I mean, if you're, yeah.
You know, Dr. Ahmed, having the dry blood spot, the kits in my drawer beside me, and thinking every day I have to see patients with hypotonia, patients with muscle cramps, or those patients. I honestly, having the test readily available will always help you think Pompe, think FABRY. Even though sometimes I've seen patients, and then I recall, yes, I've seen this patient. This patient actually might be Pompe, or might be a late onset Pompe, and then I look into my files, and then I try to pull the patient back, and then I do the test. So having this is easy, actually, and very helpful in order not to miss a treatable disorder is really very, very important.
Because in regards to treatment, and this will be one of the questions, treatments do make a difference.
Yes, for sure. Yeah.
And
so yes, it's not makes a difference because simply, let's say it at least stop the progression of the disease. At least it improves the life expectancy. It decreases the comorbidities, the respiratory problems, the deformities, scoliosis. Yesterday, actually, or day before yesterday, particularly, I had a boy who's 6 years old, and the father brought him concern about hyperelasticity of joints, skin elasticity, and this funny gait. And then he asked to go to the washroom, and then I didn't notice actually the father. And then when he took the child to the washroom, he turned around. He has severe kyphoscoliosis, very interesting kyphoscoliosis, and he has also a bit mitosis and more on the left side. When he came back from the washroom, I asked about the history, and then I'm planning actually to do for him next week the test. So it's very important to always keep this diagnosis in your mind so that you will not miss such cases.
I mean, I think it goes back to the old saying: the eyes don't see what the mind don't. What the eyes don't see, what the mind doesn't know.
Exactly.
So if you don't train yourself or you don't think about it, you won't see
True.
the symptoms.
True. Yes.
So we have a question from Ali Saeed. Thank you, Ali. Which treatment is the most effective? Enzyme replacement, substrate reduction, stem cells, or enzyme fixation?
Wow, this is a whole lecture.
Oh, okay.
A whole lecture. Yes, I think we need to discuss this topic in details. But the most important, or the aim of this talk today is really to let every healthcare professionals, including ENT doctors, orthopedics, internists, general practitioners, pediatricians, to always think of these treatable disorders rather than thinking what is the best treatment. Because every time it's the era of treatment, the era of enzyme replacement therapy in treatable disorders. Every day there is something new. So definitely yes, we have to have a complete talk about which is more effective, which is whether there is some, of course, enzyme replacement therapy might be suitable for some patients, others will not be suitable because they might develop, antibodies and antibody titer, and we need to take immunomodulation therapy. So it's a whole lecture, but the message of my talk today is to think about these cases and to how to, as simple as that, to do the dry blood spot test. And as I showed in the talk, there are the Nexus website. You just simply can register, ask for the dry blood spot test. Within a couple of days, you receive it from the company, and then within a couple of weeks, you will get the results back.
That is excellent. One final question. I was just curious.
Sure.
If you had to pick one specialty, where do you think those patients usually show up first? Like, who would be the person that would say would probably see or would need to really keep their eyes open?
This is a difficult question. So in terms like pediatricians, for sure, they are the frontline physicians, like general pediatricians. They do say, unfortunately, I can say that I've seen many cases, not for LSDs, generally for other disorders, and simply they go for the pediatrician telling him that my child is delayed walking, so he will be reassured, delayed speech, delayed anything, and then they will just reassure them, and then you will find out the patient coming after 2 years and are quite late, This is in terms of pediatrics. In terms of, for sure, for orthopedic, they do see in cases of late onset, they might see lots of deformities, and it's very easily missed. And, fortunately, I'm working in collaboration with one of, I'm not sure, Dr. Mari Karim, if you know her. She's in pediatric orthopedic, used to work in SKMC. So she's always resending me all the cases. So we have been diagnosing many cases if the orthopedic physician is really minded with deformities and what's behind it.
Okay.
Yes.
Good to know. I'll keep my eyes open for patients with orthopedic deformities.
Yes, please.
Honestly, I just want to tell you thank you very much. It was a very interesting educational lecture, and even though it's pediatric, but these patients grow up to be adults sometimes, and we see them. So
no, actually, the late onset, you are the one who will see them. So they present, yes, for sure. And FABRYs also, they do present mainly, they are missed during infancy, childhood, and basically they present during adolescence, or they present, unfortunately, with end-stage renal failure or cardiac problems or strokes. So you have to keep in mind those strokes of idiopathic strokes or without any significant family history.
No, that's true. I actually have the little testing kit in my top drawer, so I'll gotta keep my eye, especially for FABRYs.
Thank you, Dr.
Thank you so much. It was a pleasure seeing you, and hopefully, inshallah, we'll see you again someday in real life.
Inshallah. Hopefully, inshallah. Stay safe. Thank you.
Thank you.